Good morning. Good morning. I'm glad to see everyone here this morning. This is the Insurance Subcommittee on Life and Health. We're going to begin with a prayer from Chairman Williams.
Thank you, Madam Chairman Lady. Let us pray. Dear Lord, we thank you for this day, and we thank you for all your many rich blessings that you give us. We ask you to be with us. We ask you to hold you in the palm of your hand and lead us, guide us, and direct us. We pray in all these things. In Jesus' name, amen.
Thank you. We have several bills we're going to hear this morning, and this is a hearing only. And let's see, the first one on the list is Representative Douglas here. Okay, we will move down to Representative Glaze. If you'd like to come present your bill, do you want the podium? Go right ahead.
Good morning, Madam Chair and my colleagues.
Good morning. Morning, morning.
I think I'm going to stand over here. That's in the way. Just want to make sure that we have the substitute LC 461095S. I can repeat that, LC 461095S is the substitute. So good morning again. As I stand before you this morning, I stand before you with House Bill 373. House Bill 373 is a part of what we need to happen in Georgia for our men. We have had several bills that came forth that support prostate exams. We have our insurance industry that allows for prostate exams at 50 years old. What has happened now, we've got a certain group of men from 40 to 49 with family history. We have veterans who are now experiencing prostate cancer. In 2025, it's estimated by the American Cancer Society.
Excuse me, could I get you to use the microphone?
Okay.
Thank you.
But this is kind of in the way.
It'll bend down.
Okay.
There you go.
Thank you.
Thank you.
So in 2025, the American Cancer Society estimates that there will be about 10,000 new cases of prostate cancer in the state of Georgia, and those more likely will account for over 1,100 deaths. Georgia has the 5th highest prostate incident cancer in the United States. It has the 8th mortality rate of prostate cancer. And you said we already have insurance at 50 years old that you can get this prostate exam through PSA or DRE. But what we want to do in this bill is to target our men 40 to 49 who have a family history. Family history includes first kin, so uncles, fathers, sons. They are more likely to have someone in their direct line to also become a prostate cancer victim. Veterans are the highest, we have the highest number of veterans in our state. Veterans are 2 times likely or more likely to get prostate cancer. This bill would encompass and target our veterans, 40 to 49, and those with what we call, and what the American Cancer Society says is our men who have family history. We are asking in this bill that private insurance would pay for this during the annual exam. The average cost of this exam from 40 to 49 would be average $33, the lowest $18 up to $84. But the lives that it would save is irreplaceable. And one of the factors that I think we need to understand is that most of the signs of prostate cancer do not show until you're at the last stage. But screening can catch prostate cancer in the first stage, and we can prevent it. So most of these deaths, if it's in the space where we're 40 to 49 and we can get this prostate screening inside of our private medical insurance, we can begin to save more lives in Georgia. I do have the PowerPoint that is sitting before you with more information. I'd like to open it up for questions.
Does anyone on the committee have a question? Okay. Let's see. Yes, go right ahead. I'm trying to figure out which one.
Thank you, Madam Chair. First of all, I want to say thank you so much for bringing this bill, because I did not know that insurance didn't cover from 40 to 49. And it's with prostate cancer running in my family, I think this is a wonderful bill to have. What made you do this bill at this time?
I'm so glad you asked, and thank you. So I am from House District 67, and I have one of my constituents with me this morning, Derek Holloway, who is a cancer survivor. He brought his case directly to me as I was going through prostate cancer screenings with my older brother, who now is being treated. And so as we discussed and talked about his treatment, and now he being cancer-free, we decided at that point that we needed to do something about those with a family history. He did not find out his family history until after he was diagnosed. And the good thing, he was diagnosed early. And as you can see, he's sitting among us today, cancer-free and looking really good. We have, in my family, 5 uncles. 3 have died from prostate cancer. And so 3 cousins, my brother has it. It is something that we can do to prevent those with the family history to catch this early and to make sure that we give them the best treatment. It's going to be less costly for insurance companies, and it will save more lives.
Thank you. You have another question, Chairman Mathiak?
Thank you, Chair Lady. I'm looking at TRICARE because I know that that's kind of near and dear to your heart with the military. So is TRICARE doing anything for preventative in this age group that you're asking us about?
They actually, I put a page in there for you so that you would know what they're doing. Actually, private insurance and TRICARE are doing the best. They're actually catching it, and 75% of their members are actually in high risk, are being identified by doctors, and these tests are being considered, and they're using them so that they can identify early stages and begin to treat it.
Okay. Follow-up question?
Yes, ma'am.
Sure. And then what about our firefighters?
And that's exactly right. Firefighters are at the second highest risk, and we believe we can catch them in one swoop if we start at 40 to 49, and those firefighters will be a part of that. So we believe that just catching it earlier than 50. Right now, we do allow the insurance, private companies, and our state and Medicaid pays for these exams starting at 50. But in many cases, it's too late, and we need to do it a little earlier if you're in the target group for family history.
Great. Thank you so much.
Chairman Williams?
Thank you for bringing this. Thank you for bringing this to our attention today. I know a lot of us men are kind of hesitant to get blood work and other exams, but I know whenever I'm 53 now, but before before I would turn 50, I know if I had blood work or if I was buying life insurance or if I was having a physical, you know, they would run a blood
Next.
panel and they would do a PSA test. And if there was anything that looked funny, you know, then they would follow up. But as long as my markers were fine, so I think the insurance companies are doing that right now under preventative for wellness, because there are like 63 different items that are covered for children, men, and women. And I know mammograms are covered, but you know, I know the blood work is being done. So you're wanting more invasive done before 50? Is that what you're asking?
Yes, it does. You're correct, sir. It does start at 50, where the insurance in Georgia is required to actually do the PSA and the blood work. But 40 to 49, there is a target group that we're trying to add in there, and those are the ones who have the family history.
Okay, I see what you're saying. Thank you.
And, you know, and so veterans, firefighters fit in that group. There is a history in those particular groups that will allow, if this bill was to go and pass, then that means that anybody in the target group, 40 to 49, would also get the same type of test you did without a cost, and they'll be in their annual exam.
Okay, thank you.
Are there any other questions? I don't see any. We do have someone that signed to speak to the bill. That would be Derek Holloway, if you would come to the microphone. And Jesse.
Good morning, Madam Chair and members of the committee. I would like to thank you for the opportunity to testify today in support of HB 373. As a Georgian for 34 years, I'm asking that you support HB 373 that will cover and cut the out-of-pocket costs for prostate screening for high-risk men. You may already know, but 1 in 8 men will be diagnosed with prostate cancer. 1 in 6 high-risk men will be diagnosed with prostate cancer. Every 15 minutes, someone will die of prostate cancer. So by the time we leave this session, 4 people would have died from prostate cancer. But if caught early, 99% of the men will be alive in another 5 years. I'm one of those high-risk men and one of the survivors for about 5 years. But my story might have been different if I had not caught prostate cancer. I might have been like my uncle who passed away, and I just found out that he had prostate cancer after I got diagnosed with prostate cancer. And I might have been like some of the other high-risk men, some of the veterans, some of the other high-risk people who have family history. But going back into August of 2000, I discovered that my PSA was 6.99 on a scale of 1 through 4. My physical was not even scheduled until 8 months later. But I did find out, because I was going to a urologist, that my PSA was 6.99 on a scale of 1 through 4, so that was elevated. So because my PSA was high, they wanted to run it again, and then when they ran it again, it escalated to 8.08, and then they ran it again in another week, it escalated to 12.6, and then they ran it again and it escalated to 14.45. So as you can see, that my PSA was just rapidly growing exponentially. And so I had to go get a biopsy, and long story short, it determined that I did have prostate cancer. While I was devastated with the diagnosis, fortunately, I caught it before it spread. I had absolutely no symptoms. I was walking around, considered myself a fairly healthy young man, had no symptoms at all. But if I did not have access to this blood test through my insurance, if I did not have access through this blood test through my private provider, then I would not be standing before you today, because I would have had no idea. Like I said, I was walking around, had no clue. My PSA was just elevating, just at a rapid level. So that was the only thing that triggered for me to go ahead and get the biopsy to discover that I had prostate cancer. So I speak with so many other men who are high risk with similar stories. Some are darker than mine. Some find out a lot later. Some find out when they're at the very, very last stage. Some find out when it's actually spread to the bones. and it's hard to recover from that part. So now I have to be screened every 3 months for the rest of my life just to make sure that prostate cancer does not resurface again or does not reoccur. And I actually just got tested again this week, and it was 0.09, so that's a great story. But I'm one of the fortunate people because I have access to get my PSA screened. A lot of people don't, so that's why I humbly ask that the committee support this bill for screening for high-risk men. Thank you.
Thank you very much for sharing with us. We have another person that would like to speak to it, Jesse Weatherington. If you'd come to the podium, please.
Good morning, Madam Chair, members of the committee. My name is Jesse Weatherington. I'm the president of the Georgia Association of Health Plans, which is a trade group representing the state's commercial health benefits industry. We are opposed to House Bill 373 as written. Understand this is a well-intentioned piece of legislation, but we're concerned about some of the consequences. Particularly, I have not seen the substitute, but with the portion of the bill in Section C, Paragraph 1, relating to the prohibition on cost sharing for individuals receiving these tests in the age range that the sponsor described. We would want that piece excised from the bill. We think it's reasonable for there to be cost sharing. As Representative Williams pointed out, there is coverage for a lot of PSA tests in a lot of health plans in the state now, but those should be subject to cost sharing as any other part of the benefit would be. And we would also definitely urge people to have more or less invasive procedures first to try to get to this based off their risk profile. So that's kind of our position, long and short, on this legislation. I also would note that it has an impact in SHBP and Medicaid, so the bill would require a fiscal note. I'm not sure if it has one as well.
Okay. Representative Davis?
Thank you, Madam Chair. Do you disagree with being tested, the men being tested from 40 to 49?
No, ma'am. They would just need to have their cost sharing like they would for any other part of a health benefit that would be subject to that. The U.S. Preventive Services Task Force is the body that recommends what items are considered true preventive care and would be free from cost sharing restrictions, and so we would want to follow those guidelines versus having a state level mandate for something like this. Again, they do have access to those treatments now. There may just be some cost sharing. I think the sponsor shared the test could usually run about $40, $50, she said, so we think that's a reasonable burden for them. Versus everybody else in their plan having to subsidize that care for those individuals who are receiving this. Again, it's a well-intentioned bill. We want people to get screened, but we just have an issue with that piece about no cost sharing.
Representative Mathiak?
Jesse, I don't see what you're talking about in this bill.
I haven't seen the substitute. The bill, it's in the bill as introduced. It's on like the top of page 2, I think, line 47.
Substitute doesn't have any of the things you just said.
Okay.
There's no cost sharing in there, and the Medicaid and state is no longer in there. It's just private insurance.
Okay.
All right. Unfortunately, didn't have the substitute before we were able to speak to it this morning, but appreciate
Thank
that
you.
from the sponsor.
Any other question? Thank you. We appreciate it.
Sure.
Again, this is a hearing only, and appreciate your bringing this bill. Next to be heard would be Representative Douglas. I believe you have a couple of bills.
Madam Chair, members of the committee,
Here?
I'd like to
No,
thank
this
you.
one
I
here.
know you have a big sign-up sheet. I had people flying into my office yesterday. So let's rip the Band-Aid off. Which one do you want first, 100?
100.
100. Okay, 100. If you would go down to line 70, let's get this out the way first. From 71 on, we want to omit that. I didn't have time yesterday to take it to Leg Council, but my initial bill, let me just go back first. This initial bill came forward after COVID. Me and my staff are trying to figure out how can we help the American people and my constituents in the state of Georgia and my constituents to save some money, because we knew that they were going to be on medication, number one, and whatever they were fighting during that time after we came out of COVID, that this would help them relieve some of the stress. And so what we did was my team came up, and I worked with Travis and Devin on this, and we narrowed it down to take the state health care benefit plan off of this. And I tried to get it redone now, and I didn't realize that they added it back in when we had taken it out the last time that I offered this bill a couple years ago. And so from 71 on, if I can get a friendly amendment to take the state health care plan off from 71 on. And basically, we're just 80% off of any drugs that you get rebate at the counter. No mail-in rebate. When you go to get your drugs, say your drugs is $100, now it's $20. No mail-in rebate is at the counter. And that's the gist of the bill
Okay.
on this one.
You have a, Representative Gamble, you have a question?
I guess to my seatmate and friend, thank you for this bill. So I'm looking at line 71 down, and you're saying to take out the state health benefit plan.
Yes.
But is that down to line 77, or is that, what are you suggesting
Anything dealing with the state health care plan.
Okay.
So I
okay.
think it's the remainder of this section
Through 106 to the end of the bill.
until
106,
101.
103.
101.
101. Okay.
Is that correct?
Okay. Yep. Okay. All right.
71 to 101.
Okay, are there any other questions? Did you want to? Yeah, it's a hearing only. We're not going to vote on any of them. You have several people that want to speak to the bill.
Oh, I
And
figured.
if we could, Collier Williams, if you would come to the podium.
Hopefully this will alleviate some of those
Okay.
people that came to speak to the bill.
Good morning, Madam Chair, members of the committee. Thank you very much for your time today and allowing us to speak with you this morning. My name is Collier Williams. I'm with the National MS Society, a member of our Government Relations Advisory Committee. I'm here today to express our strong support for House Bill 100. Multiple sclerosis is an unpredictable and disabling disease of the central nervous system, often requires prescribed medications known as disease-modifying therapies. In addition to other supplemental medications these patients take to combat symptoms of this disease. According to a survey released by the National MS Society, 40% of people who take a DMT altered or stopped taking their medication due to high cost. More than half of respondents are concerned about being able to afford their DMT over the next few years. House Bill 100 would require that insurance plans and pharmacy benefit managers, or PBMs, share the financial benefit directly with the consumer at the point of sale, ensuring that at least 80% of these negotiated rebates and discounts are passed on to consumers, thereby helping to lower these out-of-pocket expenses. This is a major advancement towards addressing the high cost of prescription drugs, benefiting not only MS patients, but all those reliant on essential medications for their health and well-being. Thank you very much for the opportunity to lend our voice on this very important issue today. We urge you to vote in support of House Bill 100 to lower out-of-pocket costs for patients at the pharmacy counter in your district by requiring PBMs and insurers to pass the savings along to the consumer where they belong.
Thank you. I
Thank you.
appreciate your sharing with us. We have a couple other people that would like to speak to it. Jesse Weatherington, if you would come forward again.
Thank you, Madam Chair. Again, Jesse Weathington, President of Georgia Association of Health Plans. We're very much opposed to this proposal, as we have been for the past several years. This bill has popped up in some form or fashion, I think, for the last 5, maybe 6 years in the General Assembly in various aspects. And really what this bill is about the relative market share of brand name prescription drugs and a benefit. This is a mandate on small businesses, particularly, that are the ones who are paying most of the premiums for these plans right now. They enjoy the ability to take those rebates and they give those discounts back to the entire pool. So that entire pool of people who is in an insurance plan benefits from the savings that they're able to negotiate through their plan or their PBM for that rebate cost to the prescription drug. We know brand name prescription drugs cost 7 to 8 times as much as generics. There are no rebates for generics because they're actually affordable at the point where they don't need to negotiate a large discount for people to be able to get them. And so what this does, it kind of turns insurance on its head, where the individuals, and there's probably about, I think, previous years this bill's come up, about 10 to 12% of individuals that are taking a brand name prescription drug typically in a year as part of their insurance benefit. So what this does is it really subsidizes those people at the expense of everybody else in that pool. And we feel like that's unfair because, again, the people in that pool are the ones who are paying the cost to those individuals to get that discounted drug in the first place, and for all of their other care to be subsidized in their insurance pool. That's the principle of insurance and group pooling of risk. The other reason is this bill is really not necessary. Many of our members already sell point-of-sale rebate plans. They're currently available in the market today, and there's not a lot of uptake on them for some of the reasons that I just outlined to you. They're a little bit more expensive in terms of the premiums because you're having to subsidize those brand name prescription drug consumers that are part of that pool. And so we would say, don't pass a mandate that takes away all plans that currently are offered that are not point-of-sale rebate plans, and mandate that small businesses and individuals have to go into a point-of-sale rebate plan that they could buy today, but for whatever reason in their own judgment, they've decided not to do that.
I have a couple questions. One, it appears to me that ERISA plans would be exempt from this?
I believe
because
this
they-
version does have that exemption in it, yes, ma'am.
Okay, and the state health plan also?
Again, because with the
Okay.
amendment that the sponsor, but again, that would have the impact only fall on small businesses and individuals at that point.
Just as a payer, I've tried many times to find out what the rebates are and what the actual costs are, and that is something that's never shared. So how would they even know at the drugstore what the rebate would be?
That is one of the difficulties with implementing this, is sometimes even the rebates are finalized, post-period, so they could be negotiated on whatever your relative dispensing amount was in a quarterly basis, and they're adjudicated in arrears, and so it would be difficult to calculate what the rebate should have been at the point of sale.
Okay, that was my concern, because I've tried to understand how the rebates have worked in the past and can never get to the bottom number. That's that's a PBM problem. Thank you. Yes, Representative Davis?
Thank you, Madam Chair. That was my concern also, because a number of the complaints that we have received, a number of the consumers are not receiving the rebates. So if you are against this, then I'm curious as to how can we ensure that if there are rebates, it makes it down to the consumer?
So the consumer presently is getting the value of the rebate. They're just getting it in their discounted premium when it's applied to the entire pool. They're not getting it at the point of sale when they go get that particular drug on that particular day. But everybody that's in the pool is getting the benefit of the rebate collectively by having their gross premiums discounted.
I don't see any other questions. Thank you.
Thank you, Madam Chair.
Oh, I'm sorry, do you have another question? Did you still have another question, Representative Davis?
Oh, no.
No, okay. Okay, and we have one more. Cash, if you'd come.
Good morning, Madam Chair. Cash Reddy with PCMA, the National Trade Association for the Pharmacy Benefit Managers. I was going to say everything Jesse did, less eloquently, of course, but I can stand for any questions if you guys have any. We are opposed, as we have been in the last 5 years.
Okay. I don't see any questions. Thank you very much. Okay, and I believe you have another bill.
Yes.
Thank you.
And just to note, that before I go into my other bill, this measure was passed 5 times. Yes, Chairman, I want to say that was Over Health passed it a couple of years ago. It was actually a different form of my bill. That my bill never got out of committee.
Okay.
But here we go, House Bill 101. Madam Chair, just what you asked about, we're going to bring the state health care benefit plan out of this, but we do want the other agencies to come report to show us at the state the savings that everybody made. This is just basically come tell us what you did and how you did it and how much you're saving your constituents and the state of Georgia. So this is come show me bill. Come show me what you did. If you say you did rebates, you gave discounts, we want to see those discounts, and we want it reported to some agency that we have set up here at the state. We want them to come to report to us.
Okay. I get that. Are there any questions? Does anyone on the committee have a question? I don't see any, and no one has signed up to speak to this bill. Thank you very much for bringing these. Again, this is a hearing only today.
Thank you, Madam Chair.
Thank you.
And committee.
Thank you. We have one more bill, and it is my bill, and it is going to be, it's a substitute to House Bill 420, and this addresses cancer imaging, and when you have genetic testing, this has been an issue for us, and this particular bill is going to require carriers to pay for genetic testing when you have family history of these diseases. Specifically, we're talking about cancer here, and it would be covered under health plans. That's basically what the bill does. It does have sharing of copays, so if you do get it done, it would be treated as any other condition, and it would be subject to coinsurance like anything else. But we just want to make sure that genetic testing, they have such a high value today, that it's including in health plans. Are there any questions?
Yes.
Okay. Chairman Mathiak?
Yes, thank you, Madam Chair. This is specific to cancer.
Yes.
So we're not looking at we're not, you know how I am about lists. but-
Yeah, it covers genetic testing for an inherent mutation of any variant of a gene, if you
Okay.
look at 20.
Thank
But
you.
it's relating,
I got it.
yeah, there
I
we go.
got it. Thank you.
Thank you. Okay, I see no other. No, he's fine with this. Okay, there are no questions, and this concludes our business, and we are adjourned.